I am really pleased to be here. I really have learned a lot during these 2 days. I'm sorry that I'm Spanish, so this is my sexta time, but I will try to keep your attention during my short presentation. And before starting, I want to tell you that I'm here representing the European Society of Cardiology because I am a clinical cardiologist. So what I will try to do is to try to show you what have been the problem during my work in the hospital for these years and how are trying to solve it at the local level. So I might be biased because I'm a cardiologist, and most of the cases and examples that I have been involved with are, of course, cardiologists, but I'm sure that you can extrapolate this to your day-to-day professional domain, wherever you work, because at the end of the day, as someone said, medication error is a failure. So when I was thinking about this talk, I just sit down and say, well, what in my day-to-day practice, what are the factors that influence medication errors, and when I had it, and where my team had it, and when my department had it, and where all the hospital were really aware or shocked by the medication error. And I think that they could be summarized that they can be related to clinical practice setting. Remember, I'm a cardiologist. You will see the next slide, where it really will depend where you're working. They could be related to patient profile. They could be related, and I have learned a lot about confusing prescription or confusing packaging, and I will put you some examples in cardiology. We didn't have talk, but due to the way that we are practicing now medicine, at least in the European countries, they could be related to poor functioning of medical individual and team. You can't forget the stress that we spend every day in our day-to-day practice. So we will move on to the first point. From my point of view, are the factors related to clinical practice in cardiology? I'm sure that you can extrapolate that to more specialties. You realize that medication error can be close related to the domain, the place where you are working. And treating an acute care patient has nothing to do, it's completely different to treat a patient in the ward and to treat an outpatient clinic. You have to spend different time with them, with different people, and the domain is completely different. In acute care setting, which is the emergency department, and in my case, the coronary care unit, we have to make quick and prompt decisions because the patients can die in seconds. Most of the agents that we use are IV, intravenous. The medication set, which is important for all the team, has to be set up in advantage. We will talk about storage and what happened. I'm going to put some examples of what happened in my day-to-day practice in the emergency department. And in this case, you should realize that the teamwork amongst nurses and doctors are a key issue. I mean, if I have a cardiac arrest, the first thing I do is to look around me and to see who is the nurse, who is the assistant of the nurse. And I know how things are going to go, depending on who they are. So we need a team that is educated and can work together in this setting overall to avoid medication error. This is completely different if you're working in the ward. In the ward, the patient is stable. The patient is hospitalized because has to be prolonged his hospitalization for different reasons, but normally it's in the acute is completely different to the acute setting. So what you need to do day to day, and you have to see the prescription different depending if you do through IT, writing, you have to give day to day when you go to the floor clear instructions to nurses and also to the patients. The patients are stable, and so you need day and day telling them why he's taking this pill or this drug, and why if he has to take it when he is discharged. And in this case, you have to begin to talk with transparency to give information to the relatives. The patient is going to be discharged from the hospital 2 or 3 days later. Most of them are old. Most of them you have heard that have comorbidities and polypharmacy. And so you have to talk with the relatives and to teach them how to help the patient. And when you are in outpatient clinic, you have an appointment, I wouldn't say that you are calmer because you have a lot of patients, but you have to bear in mind overall the patient profile. So it's completely different to treat a young man with an MI than an old patient with heart failure. regarding to the possibility of a medication error. I'm going to put you some really important medication errors that we have in Spain, and the most important, at least in my practice during the last years. We have talked about devices. I know that the EMEA doesn't deal with devices, but at the end of the day, all the drugs should be administered through a device, whatever it is, mouth, whatever. But some of them have to be administered by IV devices. This has been an important issue in Spain in a hospital, and is in the acute domain. You can see in the picture how the nurses and the doctors we are working with patients. Below all these things you see here is a patient. So you see that he is in a pump, he is in respiratory help, he has a lot of IV infusion, bioactive drugs, etc. So what happened to this patient is that there was a big mistake through the route of administration, and they give the enteric nutrition through a IV connector. And the patient, of course, died in following the 3 minutes. In this case, if you analyze, and I went to the committee in the hospital to analyze what happened, unfortunately, and it was always happening, and David pointed here the first time, normally a medication error is not one reason. It's a lot of variable reasons that come one another, and unfortunately ends sometimes to harm an awful outcome. And in this case was that, like it used to be. It was a patient in an acute setting with a lot of IVs, a lot of pumpings. There was a nurse and a training nurse. The nurse who was taking care of the patient, when he was to administer the enteral nutrition, had a cardiac arrest in the side beside, so he had to attend and tell the training nurse, please give him the enteric nutrition. And the training nurse, because she had to attend a cardiac arrest, the training nurse just connect the enteric nutrition to the IV. So when we analyze step by step in order to avoid that to happen again, how an enteric nutrition can connect with an IV, because that never happened in the hospital. So we went to see it. And what happened in this case is that the manager of the hospital, because it was cheaper, bought 1,000 units of a connector that can connect to the two roads. So we changed. It was a huge change in the hospital, and the connector was changed. So as you can see, this is a good example to see that you have to really learn of your failures. And maybe it's a chain, but in some case, one of the chain process can be stopped by doing the thing right. Second issue is factor related to patient profiles, a little in cardiology. But I suppose that you can extrapolate this to another domains in medicine. You know that medication area, and you heard yesterday in a presentation that are related with age, but age, at least in cardiology, is more than age, it's functional state. You can really have to know, and you know, because we have a lot of chronic conditions, and the age doesn't mean many times a lot. But in any case, the elderly people play a key role, as they account 34% of all written prescriptions. So the chance to have a medication error in old people is higher. In cardiology, you have a big problem recently about medication error due to after an acute event. You can imagine a patient of 50 years old who has an acute MI. That means that he's healthier one day earlier. So, or at least he's only taking statins because he has a high cholesterol level, but he's healthier. He's not a patient, he's a healthy people. So he comes to the hospital, he has an acute MI, we do a primary PCI, we run, and in 2 days he has to go home, he's discharged from the hospital with at least 7 pills. And 7 pills with the problem that he has an MI and he's going to be a chronic condition. So the consequence of all this information in a patient that 2 days earlier was healthy people is that they come 3 or 4 days later with an incorrect dose, taking the pills in the wrong time, forgetting some pills, stopping too soon. So we have to really face this patient and this problem with a different perspective and try to spend time with them, which is time consuming, and try to explain them everything. So this is a teamwork. Chronic condition, I talk about it, is completely it's another factor related to the patient profile. You know that elderly patient and overall patients that have chronic condition, they have comorbidities. We say them in our clinic patient every day, and they are polymedicated. Some of my patients take more of 12, 30 pills, 13 pills per day. And I just have this point because I had a patient last week in the clinic who had a medication error. And this, in fact, I was really surprised that this point was on the table yesterday. My question is, what is happening with the use of generic? Do you think that medication error are increasing or decreasing? So from my point of view, and this is a case I had 2 days ago, is increasing. See, in this slide, one hand is one product with a brand name, and he was taking this product all his life for nearly 15 years. And now it's changing, and the other side, the other hand are the generics. But the generics is that they go to the pharmacist and they give every day or when the box is finished, not the same generic, but that one. So the patient, is absolutely and totally confused. And this is only with one agent. Can you imagine this with the 5 pills that they are taking? So this, in this case, and I have another colleague that have another one last week, they descended with an unintentional overdose. And you have to take into account that the unintentional overdose are the 40% of the emergency department visits. So I think that this generics is a huge problem in polymedication patients. Next point related to the medication error is confusing prescription. This is not a cardiology case, but I just put it on my presentation in my team because it was related to me, and we have heard about the error due to written and handwritten, and this is me. So the issue is that is my brother-in-law. My brother-in-law, he's a lawyer. He is absolutely sportive, and he is perfect, and he's 40, and he was having a gastric pain. He went to the gastroenterologist, and he was diagnosed by a gastric ulcer. I didn't know that, and we were having lunch, and he was sleeping. He was sucking a pill and completely falling asleep. I said, "Are you wrong? Is something wrong with you?" I said, "Yeah, since I have a gastric pain and I'm taking the pill at gastroenterologist, I'm sucking I'm feeling sleepy and my pain still. I have a gastric pain and I'm feeling awful." So I said, "Well, what are you taking?" I didn't realize that any gastroenterology pills induce sleep. So I saw it and the prescription, and he had not the prescription. So we went to the pharmacist, who is a friend, and said, what are you giving to him? And he gave him Atarax. Atarax in Spanish is an antihistaminic, and Almax is the antacid. So the pharmacist who make the mistake, because reading the prescription, he told me, "Okay, do you have a free prescription? Just write Atarax and this is my writing. Just prescribe Almax." I write it, and you can see that even me, knowing that, I couldn't make an easy mistake. So we have to, this is changing now in Spain because most of these prescriptions are done by IT, but you have for a nice presentation about A, X, all the name, and try to change everything. But at the end of the day, my poor brother-in-law was taking an antihistaminic, and the pain continued, the gastric pain continued, so we avoid that. And we have heard about the complicated packaging. This is really, really important overall in the emergency department setting. And the most important mistake is the confusion between milligrams and milliliters. You have to realize that we are working with patients that they are in death. They can die in minutes. So I think that it was 1 month ago, we had a patient, and I'm talking, and this is not solved. We had a patient with a tachycardia, a supraventricular tachycardia, that it was hemodynamic. He was the blood pressure was going low, 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 low. So I had to decide the cardioversion or the drug that we use to cut the tachycardia, which is adenosine. And we always try the pharmacology therapy before to leave the patient and to give a cardioversion. So I asked the nurse, "Give me adenosine." And the answer was, "I'm sorry, we have today the yellow thing is the green thing." say, I want adenosine, I want 3 milligrams. We learn the milligram that we have to give the patient. We don't know anything else. So I said, well, what are you talking about? And the blood pressure was going down. And said, no, we have 4 milliliters instead of 2 milliliters. I don't know what it is. I just want 3 milligrams. So at the end of the day, we have to sleep the patient and to give the cardioversion. And so I'm just trying to go to the pharmacist to say, okay, we need one, and in the emergency department, this one and storage properly. So these are examples of the factors that I think that may influence my day-to-day practice. And another one, we don't have to forget that we are individuals, and in this domain, we work with a team. So our work has stress. There are people who could have lack of motivation, their organization disorganization. There could be due the medication error to poor communication. We will talk, and I will talk about the blame-free culture or not. Maybe some teams have inadequate leadership that they try to hide the errors. And overall, we have here most of the time, we have to identify, analyze, report, and then with a good quality data, try to see what have done and try to avoid that happen and to make preventive measures if we can. So from my point of view, what could be the preventive measures in the process that you have seen? Because it's not one reason mainly. Systems is a whole system. It's not individual. It's a system that have to be moved forward and trying to change. The systems are needed, and we have learned these days to identify. There's experts here that I learn a lot from. Identifying the medication error. We heard a lot about reporting properly. We need to analyze the data that they are getting. They have a huge amount of data, and you have to analyze. But to me, it's important that their system needs to reduce the risks for medication errors with a non-punitive culture of safety. Doctors are afraid that an error is a failure, and a failure should not be known. So we heard yesterday about the mechanism for reporting errors. So the pitfalls, as I have said, we need a blame-free culture. So we need to trust in the system, and the system has to be anonymous. So, and I am surprised that I haven't heard a single word here about time consuming. We spend our time seeing patients, running. Everybody works a lot, but we work a lot to diagnose the patients, treat the patient, and if there's a medication error, to solve it. But we don't have time to report it. And if you ask in a hospital or anything, who report the errors? Sometimes it's the nurse, sometimes it's nobody, and the doctors, they don't report. And they report because it's time consuming, and you don't have the facilities within the hospital and within the system to help you to do it. So you need help in this sense. And you need help to make it more effective and easy. And in this sense, I just want to point out that the Spanish Medicine Agency is making it easier in the last of January, 2 months ago. Just you have to go to the website and click 3 times. Before it was a mess, you didn't know what it was, the yellow page, but here you have to click 3 times, and in 3 times you got the rules for reporting healthcare professional the medication errors, and the same if you are a patient. So that could solve and it's anonymous, which is important. That could solve partially the blame-free culture, but doesn't solve the time-consuming because we don't have time. That's the problem. So we have to really promote this within ourselves, our team, and within the hospital. So my conclusions is that medication error, you have heard a lot about the 5 rights. This is individual efforts. We have to know what we are doing. We have to know what we are working. We have to know with who we are working. And that's what you learn in the medical school. And then when you become a fellow, you have to treat the right patient with the right drug at the right time, the right dose, and with the right route of administration. But for me to conclude, I just put the 4 Ps, not the 5 rats, because I think that it's a system and it's a chain. We really need a policy, local, national, and international, to help minimize errors, to learn what we are doing here, and then to make preventive measures to continue to work together. We need the practice to be effective in every clinical setting. So you have to know where you work and with who you work. We need the people that a healthcare provider overall, from my perspective, which mainly are doctors, nurses, pharmacists. We need individually really be motivated and know what we're doing and do it right. And we really need to transmit, and the patient they need to be well informed. So this is the 5 P's that I hope that we have the system to avoid to repeat the errors. Thank you very much for your attention.
Thanks very much, Angeles. I think you stick perfectly to the time you had for the presentation. Anyhow, we felt that it will be better to have all questions in the end, so this will save maybe a little bit of time. But if there is a burning question now, one question, we can take it. Okay, please.
Good afternoon. My name is Luis Vélez. I'm a drug safety physician working for B4 Pharma in Switzerland. And I would like to ask to the cardiologist something in regards, 20% of my activity is doing the medical review of cases that we receive in the company. Yeah. And to be honest with you, 75% of the times when I'm talking about medication errors, I'm asking for a follow-up because information is not provided in a correct way. But well, my specific question I would like to ask you is, please imagine in an hypothetical case that you are, and you have a drug A, which is indicated for the process B, and the administration route is intramuscular, yeah? But in your unit, you are trying to assess the intravenous route. Why? Because another hospital has published an article recently and they got results of intravenous route. You as a cardiologist, would you like to report that case as a medication error, or maybe as a off-label use, or maybe not?
We are cardiologists, and so the cardiologists, I think that we are like the oncologists, very well practicing day in clinical guidelines. So if you are trying to change one route of administration because you heard that another hospital, that's an off-label use to me. I mean, you really need to change the route of administrations based in scientific records and a scientific way of practice. So I would say that if you change the route of administration is why. First, because you heard in another hospital, that's an off-label use. Second, if you try to change because sometimes, and we discuss a lot with the regulators, clinical investigation go ahead of regulator, or maybe companies don't apply for this difference, but there's a strong evidence that this route is better. I wouldn't say that I will apply for medication trial. I would try to go to the national authorities to convince them that before to change any route administration by my own in my department, we have to need a team and we need a committee in order that everybody knows this before to do it in a individual basis.